Good afternoon, everybody. Today we are going to have the Organ Donation Committee meeting, CME 5. And the topic will be on bone donation. First, we will start with the IMA prayer and physician's prayer by Dr. Suguna.
Good evening, everybody. IMA prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. Physician's prayer. Dear Lord, thou great physician, I kneel before thee. Since every good and perfect gift come from thee, I pray, give skill to my hands, clear vision to my mind, kindness and sympathy to my heart. Give me singleness of purpose, strength to lift at least a part of the burden of my suffering fellow men, and a true realization of the rare privilege that is mine. Take from my heart all guile and worldliness, that with the simple faith of a child I rely on thee. Thank you.
Now we will have the welcome address. Good afternoon, everybody. First of all, I welcome you all for this Organ Donation Committee meeting, the CME 5 of the series of the 5th month. This is our emblem which we have created. And this is our organ donation committee where we have the Dr. Kalidas, Dr. Sivaprakasam, Dr. G. Srinivasan from Karu, Dr. Papaya from Madurai, Dr. Kanagasala Kumar from Erode, and Dr. T. Saranan from Erode, and Dr. Suguna from Athu. Dr. Kalidas, Dr. Sivaprakasam, and Dr. Srinivasan, Dr. Papaya, Dr. Kanagasala Kumar, Dr. Saravanan, Dr. Suguna. First of all, I welcome you all. I welcome our president, Dr. K.M. Abul Hasan sir, for joining in this webinar. Today we are going to have a webinar on the topic is the bone donation. I welcome Dr. R. Gunasegaran, the Vice President of IMA Headquarters, Dr. T. Sedamil Pari, Immediate Past of the State President, Dr. P. Senguttuvan sir, the State President-elect 2024, Dr. B. Sridhar, State President-elect 2025, Dr. S. Karthik Prabhu sir, Honorary State Secretary of IMA TNSB, and Dr. S. Gauri Shankar, the Honorary State Finance Secretary. We have planned to conduct every month the monthly meeting on the Monday, last Monday of every month. That we are doing continuously, and each month we are having different topics. I request all the president secretaries and finance secretaries of all the branches. Now is that we are having only 120 to 130 people only joining this important program to attend the meeting, and they need to communicate and spread message about the conduct of the meetings to all the members whenever communicated by WhatsApp and email. Request all the state office also to send mails about the meetings to all IMA branches. So today we are going to have this bone donation is the topic, and Professor Dr. Dean Muhammad Ismail, the consultant orthopedic surgeon, retired director, Professor, Institute of Orthopedics, is going to give a talk on introduction to bone transplant, and Dr. Chandra Kumar Krishna, who is going to give a talk on importance of the bone donation, use of the bone allograft, and Professor Dr. B. Pasupati, who is going to give a talk on establishment of the bone graft. I welcome you all the three speakers who are going to give the talk today.
Thank you, sir.
Organ donation meet, to conduct the organ donation awareness meeting in all the medical colleges, because now colleges, schools and everything are closed. We are having, and also the election process is there. We are not able to conduct the programs. We will be conducting the programs from June onwards. We will be trying to conduct more programs, each at least one program in a week. And we have already released the handout in English and also in Tamil. I request all the branch presidents and secretaries to take up this as a project and to issue the notice like that. And to increase the awareness, if a person with a brain death donates the organ, the branch IMA office bearers to meet the relative during the funeral or after in their home and thank them by giving a citation, so that people will be talking well about our IMA and they will be knowing about IMA. I request all the IMA branch office bearers to kindly note this point. And if you inform whatever you are doing, that will be taken as an additional points to give the awards to your branches. In all the IMA meetings, I request all the IMA people to allot at least 5 minutes to talk on the organ donation in each meeting in the form of show the PowerPoint about the organ donation. If there is any organ transplant specialties in the specialists in the branch, request them to talk about their experience during the month. And if not available, we can invite from nearby branches to give the talk. So the waiting list of organ necessity to obtain list from the transplant and show it in all of your meetings. To observe 1 minute silence for the brain death donor who has donated the organ in the region. Then we are planning to conduct organ donation workshop to college students, paramedical staffs and doctors, so that all the procedures can be explained in detail and educate more people. And then hospital coordination meeting, that is to conduct regional or donor hospital coordination meet by inviting the donor hospital, recipient of transplant hospital doctors and conduct a meeting once in a month with the organ donation committee members in the IMA TNSP. The Transplant is the coordination team. The Transplant Authority of Tamil Nadu is the main one, which is dealing with the organs. To spread the message about transplant, request all the IMA members to visit at least to the website one time to the website to know more about the organ donation. And if possible, people can register. There is a registry created in the website. Pledging by our members, willing can get donor card. The donor card issued by them is like this, and now is that they are issuing a card like this. In that, about all the organs and everything are mentioned. And then this is our in IMA tamilnadu.com website, where if we click that, it automatically goes to the IMA state branch or IMA TN applications on the right hand top. Then organ donation volunteers அப்படின்னு சொல்லிட்டு ஒரு லைன் இருக்கும். அதுல போய் கிளிக் பண்ணா INA TNSP organ donation volunteers வரும். அதுல ஒரு கூகுள் ஃபார்ம் வரும். அதுல fill up பண்ணி we can submit. And then இதுல பாத்தீங்கன்னா the number of people registered are very less. In this, I request the people to all the IMA members to register who are all interested to donate the organs. Be an organ donor. I request all of you to please become, so that once we set as an example, then only we can mobilize to our patients. And we are going to create a new Google form of IMA TNSP organ donation committee for our IMA doctors to register, to make it very freely, easily available. This is what we have created, and the same type we are going to create for the public also, so that the public also can start donating, because publics alone, they are started asking about the organ donation. To increase about the organ donation, the awards already we have discussed with our president, secretary and treasurer in the last state council meeting, and we have already got sanction for the branch with the maximum donor registration in our website. And also the Google form will be awarded in award, and also the branch conducting maximum donor awareness meetings also will be given during this state conference, Taimakan conference. So this is this one website and what I was telling. And then regarding activities by our branches, only from IMA branch Erode, they have released a similar pamphlet they have printed, and then they have issued to the public. That's what they have done. And regarding the news about organ donation, this is in the March. There is both the person who was not having both the upper limbs, the hand transplant is being done. The upper limb transplant has been done. That is one message which I have told already. And another thing is one skin donation, regarding skin donation. My mother's sister's husband died on 21/3/2024, my Sitappa, due to old age at home. Immediately, I have arranged for eye donation and skin donation at their home. This is the 5th such eye and skin donation I am arranging in 2 years. And last month, I was telling about the first pig kidney transplant which was done. There is a modification of the pig kidney because of the chromosomal changes. And subsequently, what happened recently, the news was that the person has died. Unfortunately, this man died this month. That was the news. I wanted to put it here. And then one more message. This is Dr. S. Balakrishnan. You might have seen in the WhatsApp. This was on 8/2/2024. He died. He belonged to Tanjore Medical College of 1959 branch. And he has already donated his organ. This is the organ donor certificate which is being issued by Department of Anatomy and Tanjore Medical College. Like this, in all the medical colleges, they are issuing and they have given the body to the anatomy theatre. This is what about the body donation. And this is the Dr. Balakrishnan from Tanjore. I don't know he is from which branch. Pattukotte. So he is from Pattukotte, I think. So today we are having the meeting and this program will be coordinated by one of our leading orthopedic surgeons, a member of organ donation committee, Dr. Kalidas sir. Thank you one and all. And now I invite our president, Dr. Abul Hassan sir, to give his presidential address and inauguration of this organ donation meet.
Thank you, Rajesh. Good afternoon, all the delegates. My dear National Vice President, Dr. Gunasekaran.
Sir, invited.
President-elect, Dr. Singutwan Sridhar, our Secretary, Dr. Karthik Prabhu, and Finance Secretary, Dr. Gauri Shankar, and all the Organ Donation Committee members and all the attendees. I am really amazed by the work done by Organ Donation Committee team of Tamilnadu IMA. Every month we are discussing about a particular organ donation. And we have been evolving so fast that we are covering all the organs and their donation aspects. And today we are discussing about the bone donation. I don't think in any other state this kind of happenings are there. Continuously every month we are discussing organ donation. And also we are planning a fiscal meet at the end of the year where we will invite more people to pledge their organs. And naturally we would become the first state in the entire country that our more IMA members have pledged their organs. As Rajesh said, it's a very simple method and everyone, I have already pledged my organs. Rajesh already, every meeting is telling this. And whoever sees this program definitely can go through the website and then pledge their organ online. It is a very simple procedure. And in addition to all the measures Rajesh said, I also like to add that to encourage organ donation in the society. The branch members, IMA president and secretary, treasurer can visit the organ donor's house either before the cremation or after the cremation and pay respects on behalf of Indian Medical Association and give that news to the press and also send this this news clipping to IMA state office so that we can also give more visibility for the news. In that way also we can promote organ donation. So two ways, one is being ourselves as organ donors, the society will be enthused. And the second thing is if we go to the houses of organ donors, the people will be very much encouraged to see this. I think we will have to go a long way in this organ donation to help millions of people with the organ failure waiting for the organs. So this particular measure or attempt definitely would help to fulfill the gap between the demand and the supply of organs. Thank you very much, Dr. Rajesh and team. Please keep up the good work. And I'm very happy to inaugurate this webinar on organ donation. Over to you, Dr. Rajesh.
Now I invite Dr. R. Gunasekaran sir, the Vice President, IMA headquarters, South Zone. I think Sir is not joined. If Sir is not there, I request Dr. P. Sendamil Sir, immediate past president, Sir, to give his felicitations. Sir also is not joined. I invite our state president elect 2024, Dr. P. Senguttuvan, Sir, to give his felicitations.
Thank you, Rajesh Babu. Respected President Abdul Hassan, Karthik, Honorary Secretary Karthik Prabhu, Finance Secretary Dr. Gauri Shankar, Finance Organ Donation Committee Chairman Dr. Rajesh Babu and his team. They are doing a very wonderful job in conducting the meeting. So I thank you for the opportunity given. Over to Rajesh.
Thank you, President Sir, for the felicitations. Now I will invite Dr. B. Sridhar, the State President elect 2025, Sir. Sridhar, Sir. Sridhar, Sir also is not there. Now I invite our Honorary State Secretary, Dr. S. Karthik Prabhu, Sir, to give the felicitations. Welcome you, Karthik, Sir. Sir, unmute.
Yes, sir. Is it audible, sir?
Now audible.
Yes, it's audible.
Yes, sir. Most respected President Abdul Hassan, sir, President-elect Chingutuvan, sir, Rajesh Babu, sir, and all leaders here. It's a wonderful program, and I think it's the 5th program you're doing, sir. Bone donation on irukku அப்படிங்கிறது ரொம்ப பேருக்கு தெரியாது. We always feel organ donation, but நீங்க இந்த மாதிரி ஸ்பெசிஃபிக்கா போடும்போது it creates a huge awareness. Congratulations for that, and the committee is doing wonderfully well, and our best supports for you, sir. நல்லா பண்றீங்க. Please keep it up, and we'll அதே மாதிரி இந்த donor cards நீங்க எல்லாம் சொன்னீங்க இல்லையா, for many people to come inside. Teamaல கூட நீங்க just give a write up. We'll try to create as many awareness as possible. With this, I congratulate the team, Organ Donation Committee, for the wonderful work done. Best wishes, sir. Thank you.
Thank you, Dr. Karthik Prabhu, sir, for your kind words. Now I invite our Honorary State Finance Secretary, Dr. Gauri Shankar, sir, to give his felicitations. I think sir has been busy with his schedule, and now I invite our Dr. Kalidas, the member of Organ Donation Committee, to take over the CME program sessions. It is mainly because of Dr. Kalidas, sir, who was very much interested by seeing the skin donation, all those things. He voluntarily came forward, and he himself coordinated all the 3 speakers, and he made a nice arrangement for this meeting. That is his enthusiasm, and he also wants to conduct more programs in Chennai. That is his more enthusiasm he is showing. I welcome Dr. Kalidas, sir, to take over the session and to start the program. Thank you, sir.
Thank you very much, sir. It's a great honor and privilege to be one of the committee member of the IMA TAMILNADU State Branch. I thank our President and the Honorable Secretary and the Organ Donation Committee Chairman, for all the office bearers of IMA TNSP for giving us this opportunity to conduct this CME program. 3 speakers we have already invited. One is Professor Demerits and Complications. Another one is Professor Chandra. Another one is Dr. P. Patput. 3 speakers, 3 stalwarts of orthopedic surgery. They are going to give us in detail and in-depth knowledge about the organ donation. First, let me call Professor Dean Mohammed Ismail. Sir, available, sir?
Yes.
Yes, sir.
Welcome, sir. Welcome, sir.
Welcome, sir. Let me introduce Professor Dean Mohammed Ismail. Sir is At present, he is head of the Department of Orthopedic Surgery, Specialty Hospital, Specialty Hospital, and he is the president of our prestigious Tamilnadu Orthopedic Association at present. He is the president of Tamilnadu Orthopedic Association, and previously he was a director and professor of orthopedic and traumatology at Madras Medical College, Chennai, and he was the chief orthopedic surgeon in Rajiv Gandhi Memorial Hospital, Government General Hospital in Chennai. The sir has held so many other positions in government service. He was honorary medical director, Cure Clubfoot Society International, Tamil Nadu, and he was a member of congenital deformities and deduction and treatment program during his medical service in Tamil Nadu government. And he was an ex-committee member of Indian Orthopedic Association, and he was a two-time state representative of Tamil Nadu to Indian Orthopedic Association. And sir was the president of Madras Orthopedic Society in the year 2014. And he was the Senate member of Dr. MGR Medical University. And he was the recipient of the Best Doctor Award from the Tamil Nadu MGR Medical University.
Welcome, sir.
Thank you. Good afternoon. And respected office bearers of Indian Medical Association, respected President Dr. Abul Hassan, President-elect Dr. Sengutuvan, and distinguished other office bearers. It is indeed a privilege to be here with you on this occasion. I thank Dr. Kalidas for taking all the initiative and to organize this. And he had been a very active IMA president of my branch, Perambur IMA, and he was doing excellent work at the time. I can understand he continued to do it in a different capacity as an office bearer of Indian Medical Association. I'm going to talk about the bone transplant. No? We all know about organ transplant, but we don't usually call it as a bone transplant. Same thing like we don't call it as a blood transplant, we call it as a blood transfusion. Recently, last week, I had the opportunity to chair the dais with our President-elect, Dr. Sengutuvan, and he showed his great enthusiasm for combining IMA with other specialty associations. He told that we will have different specialties to be with IMA because almost all of us are IMA members, and this cooperation between the individual associations and IMA is definitely going to take our state IMA to a very high level. And this is actually திருவள்ளுவர் தான் வந்து போன் டொனேஷனை பத்தி சொல்லியிருக்காரு. அன்பிலார் எல்லாம் தமக்குரியர் அன்புடையார் இன்பமும் உரியர் பிறர்க்கு. So that is what we are trying to talk here. So those, he had already told about the donation of bone. The first bone bank in India in a government hospital was at Madras Medical College. And we can definitely make a difference in others' life if we say yes to bone donation. In the scope, in orthopedics, we have the scope. There are scope of organ donations in all the specialty. And in allograft, in bone, we have a great scope in orthopedics as well as other specialties also. In orthopedic, we mainly use it in the case of bone tumors, revision arthroplasties, and other conditions. Okay. Say, we have, whenever there is a surgery or there is a problem, there will be a gap in the bone, and bridging the gap is a main problem. We can use vascularized bone graft, and we can use non-vascularized, and we can use bone allograft. We can use the entire thing as a mega prosthesis. But definitely, yes, we can use just like this custom process we can use, but it is not biological. The more metal we use, the more problem we are going to face in the future. Or we can use such expensive shells when we do a revision hip replacement, revision knee replacement. This is going to be very expensive for the patient and almost impossible in a government setup where we are constrained. The easiest way to get a bone graft is by autograft. We can take it from the iliac crest, but the problem with taking bone from the patient itself, iliac crest, is there is going to be a lot of donor-sized morbidity, including a formation of hernia formation can happen. We can use artificial bone graft substitute, but they don't have any osteo or osteoconductive potential. And again, these things are prohibitively expensive for larger areas. So there is always a need for allogenic bone because we don't have sufficient bone. And the surgeon will have a convenience of having allogenic bone of any shape, which he can easily use it at the time of surgery to reduce the surgical time. Not only bone, we can also use a meniscal allograft, you can see here. And we can use a fascia lata, roll it around and use it as a tendon. It can be used in knee surgeries and shoulder surgeries. Of course, the long bone frozen allograft is the one which can be used for many conditions where there is a long bone defect. These structural allografts will help to give more strength to the area when there's a gap. When there is a gap, we need to fill that gap and we have to give some strength, structural integrity for that particular area. That is helped by the structural allograft. And so this is the way we take allograft. When we take allograft, we'll have to, with the host bone, we'll have to tie it around so that the space between the host bone and the graft and the transplanted bone increases. That increases the possibility of union and it will speed up the union. You can use an allograft when there is a defect in the proximal femur. So we can use this sort of allograft and fix it. We can use massive cortical allograft in a few conditions. The problem is it's going to be a limited host bone substitute, and massive bone graft, again, be the problem. We have the problem of delayed in the revascularization. And corticocancellous graft is one where which we can take it from the ilium, distal femur, and the proximal tibia. Or we can also have a small deep frozen graft, like we always do a hemiarthroplasty, total hip replacement. We can use the head of the femur and cut it into these sort of chunks that can be used as a bone graft. Or we can morselize. We'll have to harvest allograft, we'll have to morselize it, and these chips can be used to fill up cavities. This is a way, head of the femur. You can see we can use it as bone chips. This can be used to fill a cavity in the bone. And there is another one is a demineralized bone. We can demineralize the bone with hydrochloric acid. This will not give a structural stability. It will mostly be moderately osteoinductive, and it will not give any structural stability, but it will help in the creeping. We call that as a creeping substitution, where the bone is formed through this demineralized bone matrix through creeping substitution. The bone graft can be from a living donor or from a cadaveric donor. And we take, if there is any diseases of unknown origin, autoimmune diseases, if there is any malignancy, we will not be able to take the bone, use the bone, take it for the grafting. And these are all the laboratory investigations we'll have to do before we harvest the bone, as well as before we start using this bone for a bone transplant, for the bone as a lot of use it for the allograft. So these are the laboratory investigations, and we should rule out these conditions. And all these bone is procured in the sterile operating room and preferably within 12 hours of the, in the case of cadaveric donation of bones, preferably within 12 hours, and it can be extended to 24 hours if the body is refrigerated to 4 degrees centigrade. I already talked about the potential living donors, like when we do a hip replacement, we can use the hip. In case of corrective osteotomy, we can take that sliver of bone. And in case when we do an amputation for the vascular ischemia without infection, that bone also can be harvested. For the living donor, again, it's the same procedure. We have to do it in a sterile condition. And once we take the bone, the ways to preserve it and transport it, it will be discussed by the next speakers. They are going to talk about how to preserve these allograft and how to use it. And we will repeat the serological testing for HIV after 3 to 6 months. In a case of deceased donor, it is say priority is for the harvest of other organs like kidney, liver, and bone comes last, because the bone can withstand long duration of ischemia. That is why the bone is the one which is harvested at the last moment. And it again will be a very sterile procedure in the same operating theater. We can take femur, tibia, we can take patella, we can take the tendons of the calcaneal tendon, patellar tendon can be utilized. This is how we harvest. We, in the case of lower limb, we get an entire incision from the thigh to the ankle. And here you can see that bone is being harvested as a purely sterile condition. And once the bone is removed, we keep this bamboo stick. That is what we used to do at Madras Medical College, or we can use any other stick here. And in case we take only part of the bone, we'll have to use a screw to fix it with the native bone. Let us say this is going to be the part where the femur was removed, and that is a stick that is drilled, that is screwed into the tibia. And just to fill up this soft tissue, there we keep some cotton wool that is going to occupy that gap which was initially occupied by the bone. So once the harvesting is over, this is how it is going to look like. And to increase the rate at which the bone union occurs with the native bone, we try to increase the contact area by using this step cut method. There are 2 ways of preserving. Again, it will be discussed by the speakers who are going to talk next to me. Deep freezing and freeze drying. And freeze drying is going to reduce the strength of the bone. So the structural strength is going to be reduced. But these graft can be stored for a very long time. And the WHO protocol, we'll have to gamma sterilize it. Probably that will be the one limiting factor to start bone bank in many places. All other facilities are already there. That should not be that very difficult. Deep freezer should not be a problem. Processing should not be a problem. The problem is sterilizing it. Sterilizing, we'll have to use a gamma radiation of 25 kg. That is the one that is going to be the limiting factor in starting bone bank in all over the places. This radiation is very important. This is how the packed allograft is going to look like. Once we cleaned it, sterilized it, and it is packed, and it is ready for transport. You can use it. Commonly, we use it in a bone tumor. We cannot use it in a bone tumor of this kind where it's, this patient is, many of the patient in government setup, they come very late. It may require an amputation, but whenever the patient presents early, we can remove the tumor. We are going to fill it up with these marcellized or bone chips, allogenic. And we can use it in spine surgery, mainly for achieving a better fusion, because in the pediatric age group, the autograft is going to be very limited, and we'll have to use only an allograft if you want to speed up the fusion in the spine. And we can use the bone along with the tendon if you are removing a part of the bone and the joint. This can be used, osteoarticular allograft. And we can also use a allograft with a composite. We can use the allograft along with a prosthesis, endoprosthesis, that is a hip replacement. And you can see the proximal part of the femur had been removed due to involvement of the bone by a malignant tumor. That was removed, and this is the allograft, and that is stabilized with this long stem hip prosthesis. This will be fixed with the remaining bone in the of the patient. There are some demerits. One of the main thing is an infection, and there is a possibility of graft fractures loosening. This can also be used in a case of shoulder surgery, where we can use an allograft to fill the defect in the glenoid. Even though we have other, all these things can be used. But if you're not able to get any of these iliac crest, other things from the patient, then we'll have to use an allograft. We can use these expensive metal to fill the gap when we do a total hip replacement. This is going to be very expensive, and many of the patients cannot afford. And so at least we can downgrade the defect. We can fill the defect with a allograft and then use a hip prosthesis that is going to reduce the cost of the prosthesis, as well as it is going to speed up the process of union of the bone. This is one of the case I did at Government General Hospital when I was there. And this patient had a defect, huge defect. You can see I used a allograft, which obtained from our Government General Hospital bone bank, and the entire thing had been filled up. And I have used a prosthesis, which is not that very expensive. Otherwise, I'll have to use a metal here, and that is going to be very expensive for the patient. And this is another patient. That was the patient came with the infected total hip replacement. And in this surgery, again, I used marcellized allogenous bone graft. And these two patients, they did quite well. We can also use it in the case of revision knee replacement. When there is a defect, we can fill it up. We can use it in the revision knee replacement. And that is our bone bank in Government General Hospital. When I was a director of orthopedics at that period, we were using it extensively, and the bone donation is definitely very useful, especially for the poor patients. And it can be donated by the live donors. As I told, after doing a surgery, whatever the part of the bone which you're going to remove and just put in the dustbin can be used. The patient is fit, and it can be used to save a patient's limb or life. Again, after any patient who is willing for a cadaveric transplant, and after the organs are retrieved, that bone can be harvested and it can be utilized. So that is the general introduction of how a allograft is used in a case of orthopedics as a bone allograft. And the next speaker is going to talk about the importance of bone donation. And Dr. Pasupati is going to talk about the establishment of bone bank in a government institution. That is not that very difficult. The only limiting factor, as I told you, is going to be the gamma irradiation. Thank you. I thank IMA and especially Dr. Kalidas, who was our president of Perambur branch, for giving me this opportunity to share a few of my ideas. I know I always fond of IMA. They are doing an excellent job. And I thank all the office bearers of IMA. Thank you very much.
Thank you. Thank you very much, sir, for your wonderful and elaborate lecture on introduction to bone transplant. Tonight, Dr. Chandra Kumar, the second speaker, who is going to talk on the importance of bone transplant as well as the allograft. Let me introduce Dr. Chandra Kumar. He is Associate Professor of Orthopedic Oncology in the Department of Surgical Oncology at Cancer Institute, Adyar. He is in charge of bone bank in Cancer Institute, Adyar. He did his MBBS at Madras Medical College, MS Orthopedic Surgery at the University, and Diploma in Tissue Banking in National University of Singapore, Diploma in Clinical Orthopedic Oncology in South Korea. He has made several publications. A few of his publications are Fate of Kyphosis in TB cervical strain, and second one is the outcome of the surgery in metastatic sarcoma. Third one is factors associated with the local recurrences in surgery in case of metastasis to the extremities. And fourth one, the ambulation recovery in metastasis of femur and preservation of extremities in soft tissue sarcoma. So many publications, with few of the publications I can read, so many publications he has made. And also he made presentations regarding lytic lesions in the proximal femur, and also bone biopsy, assessment of symptom interval in musculoskeletal neoplasm, etc. He attended the various national and international conferences, and he is very much, sir, we are very much happy to be here and deliver the lecture. Over to Chandra Kumar, sir.
I would like to thank the IMA Tamilnadu branch for giving me this opportunity, and I would also like to congratulate the team for doing this wonderful job. Many of you previously told that many of the people, even many doctors, are unaware of this bone donation or existence of a bone bank. So I take this platform to enlighten you all on the importance of bone bank and the need for bone donation. Like Professor Dean told, the use of bone allografts are varied. You know, there are multiple uses of this bone graft. It's not only used by orthopedicians, it can be used by dental surgeons, head and neck surgeons, and even in orthopedics, it's not restricted only to oncology. Even in trauma, replacement surgeries, revision replacement surgeries, spine surgeries, and sports surgeries also use most of these bone and tendon allografts. I'll share a few examples in oncology where these bone grafts are used. See, the part of the bone which is encircled by red, that is the diaphysis of the femur. That part is the bone which is used, that is the allograft. If allograft was not available, the entire femur had to be replaced. And at such a young age, it will be a total femur replacement, you know. The proximal femur as well as the knee would have been prosthesis instead of biological safe bone and biologic, which is biology. And you can see that allograft over a period of years has incorporated well into the host, and it has united very well. If this bone was not available, this is what we would have done for that patient. Both the hip and the knee would have been replaced by metal. And this is another example where it's the hemicondyle is involved by the tumor. So if allograft is available, we can just remove that part of the knee joint and replace it with the allograft. And you can see excellent union in this case also. If this was not available, then we would have done something like this, which is replacement at such a young age. You know, these people with advance in chemotherapy, these people, they live long. Now the 5-year survival has improved to 60 to 70%. And these young children, they have high energy demands, and having a prosthesis will cause repeated surgeries, because of wear or infections and failures, mechanical failures, which happen very frequently around the knee. So having a allograft would have definitely saved, he can have his biological knee, even though these patients, they develop radiologically arthritic changes, symptomatically they are not symptomatic, and they can pull off with this for a very long time actually. And this is another example where the distal radius is tumor, a recurrent tumor, which has been removed and which has been removed and replaced with the distal radius. You can see on the image on the right side. And allografts, they can also be used along with the prosthesis for the osteoarticular resections. Here is an example where you can see that green part of the bone is a allograft, which can be used along with the prosthesis. So what is the advantage of using this bone in that proximal part? Why can't we use the entire part as prosthesis? One is cost. Second, when we have bone, it has some native tissue or tendons attached to it. So we can attach the tendons, the hip abductors, iliopsoas muscles, to enhance the function of the patient. So that is the importance of using allograft prosthesis composite wherever we use. And this another figure is the proximal humerus, again used with the APC. Again, in this patient, the part of the bone which is encircled in red is the allograft. So why do we use the allograft here? Here the allograft is used so that the stem of the bone, stem of the prosthesis can be inserted into the bone. If that bone was not there, the remaining native bone is very small. The remaining native bone is very small, where you cannot insert the stem of the prosthesis. So here, and what would have been done, we should have even changed the ankle. Ankle also should have been metal. So by having this allograft, we are able to save his ankle, and native ankle is there for this patient. This is the image of that patient. Again, this is a recurrent tumor in the proximal femur, which has been resected, and allograft has been used along with the prosthesis. So this is the allograft prosthesis composite. So advantage of this is you can attach, drill holes and attach tendons in that part of the region. Again, this part, you see only this part of the bone is the native bone. The entire bone has been removed. The other part of the entire bone has been removed and replaced with allograft, which has been filled with cement, so that you can put the stem inside it. Otherwise, you should replace even the knee joint in this patient. So by doing this, this patient has a biological knee. So that is the advantage of using the allograft in this patient. If allograft was not present, it has to be a total femur again for this patient. The knee joint would also have been replaced. And this is for curettage patients in any benign tumors, where you can fill it up with some whatever available bone graft you have. And it can be used in spinal fusion, in trauma, in massive bone defects also it can be used. This distal tibia, this is a allograft. It has again been used for arthrodesis of the ankle joint. Again, bone loss in a patient. Allograft has been used. You can see excellent bone incorporation into the host. So what are the alternatives which we are having at present? We have bone substitutes and prosthesis. They are very expensive, and most of the patients in our setting, where they have constraints, they cannot afford these things. And allografts will be cost effective and biological. What are the advantages of allografts? If you have a very good bone bank, there should be no limitation to the number and size of the bone graft. And the size and shape, they can be tailored intraoperatively to match the size of the defects. And it would be definitely way more cost effective than the other alternatives which are present. It obviates the long-term complications of the prosthesis, such as mechanical wear and infections, and redo prosthesis surgeries which the patients undergo. And it is a biological reconstruction. So there is soft tissue adherence around the grafted bone, ligament or tendon can be attached, and it can be used along with the prosthesis as a APC. There is no donor site morbidity, and grafts from one donor can be used for 25 patients. The demand for bone grafts is rising. And what are the advantages of the bone bank when compared to a few things I want to compare along with organ donation? There's no matching is required, and we don't use this immediately like the other organs where the organ transplant is done immediately. So this course in using bones, I'll tell you what are the advantages when compared to the other things. One thing is, that the outcome of the patients for whom these organs have been used. So whether you want to discard the bones or not, you can follow up with that. Usually you'll get a call saying that the patient is infected or anything. So you can discard the bones. You may not store the bones for a long time. So what does a bone bank do? A bone bank basically procures, processes, stores, and distributes bone. There are very few bone banks in India. And sources of bones, where do we get the bones from? We have living donors and deceased donors. Living donors is the hip replacements and knee replacement patients. Those bones which are usually discarded are collected. And if they are good, they are processed and stored. And also from amputation. Here I would like to bring to the notice of IMA regarding the amputation. See, whatever rules we are having, it is common for all organs and tissues. We don't have any rules specific for bones or eyes or skin. What I would like to inform or tell the IMA is the bones are usually processed and we give 25 kg of radiation. So even if the patient has malignancy or any infection, a known infection, let it be hepatitis B or HPSAG, HIV or HCV, this 25 kg of radiation has the power to kill all this DNA, all infections, all malignancies. So I think the government should come out with rules specific for each organ or each tissue, because a processed bone which has received 25 kg of radiation definitely cannot harbor any living structure, be it malignancy or be it any pathogen, microbe. Everything is dead in that. And the deceased donors, we take bones from the brain dead as a part of multi-organ transplant. Wooden stick is used to replace the harvested bone. Again, here I would like to say a few difficulties we face as bone retrieval system. So what most of the patients are not aware of the bone, most of the relatives are not aware of the bone donation thing. And even if we counsel them, bone is the last structure which we harvest from the body. So by the time we go and harvest, there's so much time taken for other organs, liver, kidney, heart, or any other bowel. After that, skin, eyes. By the time we reach, the patient's attendants, they want the body fast, so that they have to go and complete their formalities. So this is one difficulty which we are facing. They are willing, sometimes they are willing, we go to the hospital with our own set of things, but by the time the bone harvest time reaches, it is already long, 5 to 6 hours is gone, and the attendants want the body back. So this is something, I don't know how we should work on this. So what are the bones which we harvest in these brain dead? We can harvest all the bones. So what we usually do is we harvest the upper limb, usually the humerus, radius ulna, from the lower limb part of our iliac crest, femur, tibia, fibula. And we also remove the patella. Patella is usually removed along with the tibia, so that it can be used as a bone tendon bone graft. And the reconstruction of the body, of the donor body, is always done with wooden dowels. POP or wires will be used to attach the anchor dowels to the remaining body. And dignity and respect for the deceased body is always observed. There is no disfigurement or dangling of the limbs. and we reconstruct the limb best as can be done to give a cosmetically acceptable reconstructed limb so that the last rites can be performed. So we use these wooden rods to fill in the gap. So processing of bones, the bone bank at Cancer Institute Adyar, we process the bones by two methods. One is the deep frozen bones and one is the freeze-dried bones. The deep frozen bones are structurally strong. It can bridge long bone defects. It's stored at -80 degrees Celsius and the has a shelf life of 5 years. The freeze-dried bones, anything which is dried has lower weight because the water content is gone. So they are structurally weak, obviously structurally weak. But the advantage of the freeze-dried bones is they can be stored at room temperature and it has a shelf life of 3 years. So these can be used to fill small cavities or in spinal fusion. These places, this type of processed bones can be used. So this example of deep frozen bones on the left side, on the right side, you can see the packed lyophilized bones. And all bones, they undergo 25 kilogray of gamma irradiation. Cancer Institute has signed a MOU with Indira Gandhi Center for Atomic Research at Kalpakkam, and they do this radiation for us without any cost involved. So how does our institute benefit? So bridging bone defect is one of the most challenging problems. We have been traditionally reconstructing with mega processes, but the best method would be by using bone, because bone will unite with bone tissue itself, and approximately 40 to 50 patients would benefit from this bone bank at our institute. And we also provide this bones to other hospitals who wants to use. So wide spectrum of patients with diverse conditions are benefited from our bone bank. Thank you. Can I just give a few slides on the bone bank at our institute?
Okay.
Yes, sir, you go ahead.
Go ahead, sir.
Go ahead, go ahead.
Thank you, sir. So the bone bank at Cancer Institute, it was envisioned by our executive vice chairman, Dr. Hemantraji. He supported the training in diploma in tissue banking from the National University Hospital, Singapore. It was a 1-year online training with 1 week of demonstration and examination, which we cleared in September 2015. The bone bank was, we visited various bone banks in India, MS Ramaya Medical College and the tissue bank at Tata. We visited various other international bone banks. We witnessed a wide application of bone grafts, which are imported from the US and sold. The bone bank at Cancer Institute was donated by the Rotary Club of Madras Central. They donated all the equipment as part of the global grant project. The bone bank was formally inaugurated in June 2019. The facility was inspected by the DMS in August 2019. We appointed a bone bank technician in August, and we registered with the government of Tamil Nadu in September 2019 and subsequently registered with Transplant in November 2019. Ours is the largest bone bank in India, over 1,600 square feet, and we have state-of-the-art equipment. Our institute is a non-profit service, and our bone bank also follows the same. We provide safe, reliable, and cost-effective human bone allografts. And the guidelines which we follow are the Asia Pacific Association of Surgical Tissue Banking. And we process bones, like I told already, freeze-dried and deep frozen. And we sterilize our bones with 25 kilogray of gamma radiation, which is the universally accepted method of sterilization. We are well trained in harvesting bones from brain dead, and we have an ambulance exclusively for bone bank, and all the instruments for retrieval processing, everything is available in our bone bank. So this is the name of the bone bank, Rotary Madras Central Prahlad Rai Sarogi Bone Bank. It is located at the basement of our Diamond Jubilee building. This is the dry processing room. And we have all the equipment like a vacuum packing machine, band sealer machine, laminar airflow, -80 refrigerators, bone cutting saw, liquid carbon dioxide for backup refrigerators. Our aim is to get ISO standards, to go for 3D printing of bones, and to work on enhancing bone incorporation like using allograft engineering. Thank you.
Thank you very much, sir, for your elaborate lecture. Let us invite Professor B. Pasupati for his talk on the bone bank in the government setup. And we introduce Professor Pasupati, is MBBS, Diploma in Orthopedics, MS Ortho and DNB Ortho, Professor of Orthopedic Surgery for the past 20 years. He is in charge of bone bank at Madras Medical College since 2018. He is the undergraduate and postgraduate teacher for the past 25 years. And he is a member of Perambur IMA, Madras Orthopedic Society, DNOA, IOA, Indian Arthroplasty Society, and Indian Cartilage Society member. Professor Pasupati, sir.
Thank you, Dr. Kalidas, for giving me the opportunity. I thank IMA TAMILNADU and especially the IMA Perambur for giving me this opportunity to share our experience with bone banking in government setup. This is a wonderful initiative to make awareness among the public, among the doctors also, which is very essential. It is the need of the hour. The right time, always IMA will be acting. I think it is a very good initiative. With this, I thank all the organizers of IMA and the secretary, Dr. Office Bearers, Dr. Rajesh. This is the establishment of bone bank in our Madras Medical College. This is the, for wherever we go, we will be the pioneer institute in Tamil Nadu to establish any new inventive things. So our bone bank was established in 2003 with the help of our CM at that time. Our Professor Mail has initiated, as a tumor surgeon, he initiated the process. We are able to do bone transplant, allograft transplant for bone disease with tumor. Initially, we used to import bone from Sri Lanka. That was the process when we were postgraduate and assistant professor along with him. We did a lot of bone allograft transplant for patients affected by bone tumors. We used to get bone allograft from Sri Lanka, and we process it and apply for our patients in 2003. That made him to start a bone bank for our own in Madras Medical College. That idea of him initiated us, and we established the bone bank in Tower 1 when it was inaugurated by the CM that time. We started our bone bank in the Tower 2 of the Madras Medical College in the 6th floor, top floor. And as we know, the need for bone donation is less recognized in the public. We used to donate our blood. We used to donate our eyes. We used to donate our skin. Like that, bone donation comes as a last. Harvesting also last. Donation also considered as the least part. But if we donate, even though it's a small thing, the need is more, and the beneficiary will be much benefited by this bone donation. So with this idea, this bone bank was started with the permission of the Transplant. At present, the bone bank functioning in Madras Medical College is headed by our Dean, Professor Therani Rajan, and our Director is Professor Singara Vadivelu. I am the medical officer in charge of the bone bank, and with my assistant, Dr. Balasubramaniam. Coming to the brief history of the bone bank, as Professor Ismail said, he was also one of the member of the bone bank development. During his period only, we are able to harvest cadaveric bone from the cadaver during 2019. So as he said earlier, the bone is the donation organ, which was mentioned by Tiruvar himself. So our Tamil people has to be the first state in the country to do this bone donation, to make our state as the best state in donating bone. Why we need an allograft? I think the slide is not coming. hopefully here. The need of allograft is well said by Dr. Chandra Kumar. Wherever there is a defect, wherever there is a need for lost bone, either because of the tumor, because of trauma, or because of any infection, the need has to be done by your fibula. That is a God-created bone substitute which is available in our body, and we try to harvest that fibula for many of our patients. We encourage the allograft also has to be taken from the fibula, at least if the public is not willing to donate more bones, at least this bone can be used whenever there is a need. So these are the indications for bone graft in orthopedics. Many of the replacement surgeries are happening, and the replacement surgeries are ending with the failures, which is going into revision. For all revisions where we go for bone, it is always difficult to get bone from a native of the patient itself. Autograft is very difficult to substitute for the need of the hour. So allograft is a very good alternative. So we can use allograft in joint replacements, in difficult non-union with bone loss, and where there is a need for bone gap filling, and the tumor where there is a big loss with bone. So we have to select the patients for bone donation. How will you select the patients? All the patients above 18 years and below 80 years are good person to donate bone. But we usually prefer person below 60 years for donating bone. The person should not be suffering from any of the viral diseases, which is include patients, those who are willing to donate, and if their age should be above 18 years, they shouldn't be free from any infection, and they should not be suffering from any chronic illnesses like autoimmune disease or insulin-dependent diabetes mellitus. So these are the criteria for us to take them for donating bone. So the steps involved in the bone donations are the process of bone banking steps are to get a consent from the donor, how to harvest the bone, and how to preserve them, prepare them, and storage recipient and giving it to the recipient. These are the steps. So for which we follow the donor consent form, we will properly maintain a record for that, and we will take a history of whether they are suffering from any illness and all, and do all the investigation. Once the bone is harvested, then we will do a culture and sensitivity and do the histopathology and the radiological examination of the harvested bone. So then the bone donors, as Dr. Chandra Kumar said, it's either a live bone donor or a cadaveric bone donor. Live bone donor are mostly from the fraction neck of femur. For them, the head of femur we will remove and we will store it. We will remove the head of the femur and process it in the saline wash, then we will do an absolute alcohol wash, and we will store it after doing all the preparatory work in a deep freezer like this. The cadaveric bone donors will be taken from the consented, branded person. Usually now the acceptance is, as Dr. Chandra Kumar said, the acceptance will be less if they are accepting. The process is delayed. As a result, we are able to harvest very little bone from the donors. So we mostly end up at the end of the day, they will be totally fed up. They want to do other routine process. Initially, they will give consent for removing all the bones, but at the end, they will allow us to remove minimal as much as we can. So most of the time, we are able to retrieve only the fibulas, both side fibulas from the patients, donors. So we, after getting that harvested allograft, we send it through the 6-step process: washing, preparation, ultrasonic, and laminar flow. Then finally, we will pack it and store in the deep freezer. Whenever this is a minus 80 degree deep freezer where we are storing all these things. Whenever there is a need for deep freeze-dried allograft, we use the lyophilizer which is available. This is the lyophilizer available with us, and we have gamma sterilization facilities available in our institute itself with the help of the radiation oncology therapist. And we are able to retrieve the harvested allograft, whenever there is a need from the recipient, we will maintain the recipient register like this. This is our recipient register in which we will record all the needed. So far, we have harvested 6 allograft from the cadaver. The live donors are more for us because we are repeatedly doing surgery. The live donors are mainly used for reconstruction surgeries with the revision hip surgeries. This is our latest live donor who has donated both fractured neck of femur, which has been replaced for a patient suffering from fracture replacement with a protrusio. The allograft harvested from this person was used for a need of allograft which is needed for this person with a bone defect. So far there are 6 cadaveric allograft donors which was utilized for a 12 recipients. These are cases for which the received allograft can be reused. This is a case of giant cell tumor of an antenatal mother had a giant cell tumor of a proximal femur. The allograft was used here. Later on, there was a little recurrence which was managed by zoledronic acid after delivery. This is another case of distal GCT of the distal radius for which we did a allograft. This is long time, more than 5 years. Patient is doing well. This is another case of a tumor of the proximal humerus for which we did an allograft. Patient is doing well. This is another interesting case of giant cell tumor of the proximal radius for which we resected the tumor en bloc and we filled the gap with the allograft with the radial head prosthesis. This patient is also functionally improved very well and she is having only limitation of supination only. Otherwise, the structural need of the defect is very well attained by our allograft substitute. This is another case of humerus fibrous dysplasia for which we did an allograft with the plating. This is another case of GCT recurrence GCT of the distal tibia for which we did an allograft, but unfortunately the patient developed a recurrence. The allograft has taken very nicely. It has incorporated. There is no loosening or any infection, but the recurrence has happened. As a result, we didn't amputation for this patient. There is a need for allograft in trauma also. High velocity injuries with the loss of bone like this, we have used allograft. Allograft is very well substituting the need of the hour. IMA has rightly organized a program to make awareness of usage of the bone allograft. We have to create the awareness among the doctors as well as among the public to know the importance of donating bone. Our institution is also very much interested in helping us in all the way to harvest bone allograft. Yesterday, we did one allograft procedure which has come in the paper, and media is also helping us to create awareness among the public. So, our donation may be simple. Donating a small bone is maybe a small thing, but the beneficiary will be much benefited by this small donation. So, we have to encourage our public to donate.
Thank you very much, sir, for your wonderful lecture and the services.
You stop sharing your screen.
Service rendered by the our government of Tamil Nadu in the Institute of Orthopedics, Madras Medical College, and Rajiv Gandhi Government General Hospital. Thank you very much, sir. Now the session is for questions and clarification.
Now the session is open for discussion.
Open for discussion.
So we can, those who have any doubts, you can start asking the questions. And there was one question which was coming first when the first talk was going on. Is stem cell therapy alternative for bone transplant? That was a question. I invite all the 3 speakers to please unmute yourself. Chandra Kumar, Krishna sir, Pasupati sir, and Dean Mohammed sir. Please unmute yourself. The first question is stem cell therapy alternative for bone transplant?
Yeah, I'm Dr. Dean Ismail here.
Yes, sir.
Yeah, stem cell therapy at the
அது
present
என்னன்னு
time.
தெரியல, ஒரு கேள்வி கேட்டிருக்காரு ஒருத்தர்.
அப்படியா? ஸ்டெம் செல் வச்சுட்டு இப்போதைக்கு இந்த போன் டிரான்ஸ்பிளான்ட் பண்ற மாதிரி எல்லாம் ரொம்ப பண்ண முடியாது.
எஸ் சார்.
Stem cells fill in the osteo induction is still on the initial stage. We use that for something like a stem cell for osteoblast therapy is used for avascular necrosis, but that cannot be used in place of a bone transplant.
Yes sir.
Allograft equivalent வராது.
Yes sir, yes sir.
The stem cells can be combined along with the allograft, sir. Allograft engineering. Because the bone is only a dead tissue, it's only a scaffold for the host to come and incorporate. Sometimes incorporation usually doesn't happen very well. So the new advances to use the stem cells along with the allograft to improve incorporation.
எந்த பக்கம் வயிறும் சேர்ந்து வலிக்குது. சரி,
Santosh, please mute all other speakers. Sir, then sir, can we use it for all people, sir? Whether bones take up easily or graft host rejections are present.
The Dr. Chandra Kumar, sir.
Yes sir.
The grafts always, they might not take up. Sometimes grafts resorption do occur. It happens, sir. But bone essentially is used only as a strut. So it can be used for all patients, sir, where indicated.
It will take up.
Not necessarily, sir. It might not take up. It might get resolved, or it can take up. Any of the things can happen. There are a lot of things which play a part. One is union has to happen, sir. If union doesn't happen, usually the bone undergoes resorption. So absolute stability is important for the bone graft. Even so, absolute fixation, we need stable fixation wherever we use these allografts. Even if absolute fixation is done, there are some times where the bones get resorption. Resorption takes place instead of incorporation.
Sir, one question. Hello, sir.
Yes,
Chandra
sir.
Kumar, sir.
Yes,
Sir, you said the HIV, HPSCG patients are not contraindicated for bone transplant.
Sir, I feel, sir, because see, I felt from the point of thing, because all hello.
Yes sir, audible sir, you are audible. You are audible.
Sir, what I felt was, see, since we are not having much bone graft, see, it might because it's not like other organs where you take it and without processing you just implant the organs like kidney or heart or liver. Here we are taking the bones and processing. Yes, the challenge is there with the personnel involved in the bone bank and harvesting. That is there, sir. I agree. Maybe not for viral pathogens, but definitely for malignancy, sir, we can definitely take the bones. See, it's a distal femur osteosarcoma. We are doing amputation. We can use the tibia and fibula. Definitely we can use those things, sir. Okay. Because there's something called extracorporeal radiation, where we take the bone from the patient who has a bone tumor and irradiate with 50 gray of radiation, only 50 gray, sir, and put it back into the patient. It kills everything, all the tumor. So we recycle the same patient's autograft and put it back. And that has shown tremendous success. It's been done for years. And here, even if we assume that the tibia and fibula has tumor in a distal femur osteosarcoma, we are going to give 25 kilogray of radiation, which is going to essentially kill everything. And this 25 kilogray, this magic number, they got it because they thought that 17 and 20 kilogray is needed to kill the hepatitis C and HIV virus. So that is why the 25 kg has come. So I feel even if patient may not be positive while we taking, but after 6 months or from a femoral head, if it comes positive also, I don't see a point in rejecting those grafts once it has been processed.
Sir, in your institution, you take a bone and send everything to this Kalpakam, sir?
Yes, sir. Yes, sir. The small bones are sent to Kalpakam. The long bones we send, which is freeze-dried, we send it to Bangalore, sir.
In Bangalore, where they are doing, sir, actually?
Microtel.
That is a private institution.
Private, sir.
So they will be charging more, no, sir?
They charge, no, sir, they charge reasonable, sir, 5,000 to 10,000 rupees for one bunch of bones.
Sir, one more question. Sir, in private setup, in individual, smaller and medium-sized hospital, when we are doing plasty for fracture neck of femur, we are removing the head. How we have to transport to the bone bank?
Yes, sir. So what we do is we have a few hospitals who regularly provide us with these bones, sir, because we are not a hospital where we do general ortho. So what we do is we give them the sterilized double pack, sir. 2 plastic containers, one plastic container inside another plastic container. That is, and it is ETO sterilized, sir. So we give around 10 or 15 packs, and that will also have a container for microbiology to take small piece of bone. So what you have to do is when you're discarding the neck head, you wash it with saline. You take a small piece of marrow, put it in the culture bottle, and put that head into the inner bottle, put it inside, and put that bottle inside another plastic bottle, which will also be provided by our bone bank, sir. And you can store it in the normal freezer, a normal refrigerator's freezer. If you have a -80, well and good, sir. And you can inform our bone bank a day or the same day morning so that we can come and collect the bones, sir. We usually collect the bones. We have an ambulance, we have a technician. So she'll come around and collect the bones, sir.
Is there any legal formality for this?
No, sir, no legal formality.
Sir, one small request from side of the IMA, I am requesting, sir. You please give a write-up for what are all the things you have told about the bone transportation and all those things. You give a small write-up so that we will publish the same things in this IMA bulletin and all those things. So that this is actually a big message for me also. Because I am involved in this organ donation and all the organ donation activity almost for 15 years I am doing. Every year I will be giving more of the talks and all those things. But this particular point about the transportation of the bone, which can be done, because a lot of ortho hospitals are there, a lot of people are taking up the bones. The major bones, we can send it to your centers. Not only from Chennai, what I am requesting is from other places also, how it should be done. We want a good, nice write-up, sir, so that we will publish in the time of bulletin, and also we will put it in the IMA website, and we will send the message to all IMA members like that.
Thank you, sir.
So you please do that, so that we will propagate more, sir.
What I would like to bring to the IMA's notice is Tamilnadu has been one of the top organ donors in the country for many years. But unfortunately, that number doesn't translate to bone donation, sir.
Sir, that's what, sir. Regarding the bone, we should have a separate workshop, sir, actually. We should create a workshop. As I was telling in the introduction, we need to conduct a separate workshop in each and every place, so that at least in the region wise we will conduct one workshop along with you, sir. Because only when you come and show the people, those who are interested, whether the consultant is interested or not, he can send any one of his senior registrars, so that they will be trained and we can start doing it, sir. We will try to create workshops for bone bank separately. We will do it, sir. In each zone, we will do it, sir.
Great, sir.
I need your cooperation also. Your available dates, when you are free, you can participate in the programs. That's what.
Definitely. Definitely.
We will take your help and Dr. Pasupati sir help also. I don't know about the same way, the bags you can give it to all the places, or in each district, one particular place we can have like that. Once we start a workshop and distributing the things, it will go in a long way. And you will be able to get more of the bones easily. So this is a very nice message, sir. Actually, by conducting this program, the Kalidas sir was the person who was initiating this program. And by this way, I was able to contact you also. So it was a very nice message, sir. Thank you so much. So regarding Pasupati sir, how about the message from the government hospital? How you are sending the messages, sir? நீங்க ரொம்ப நாளா போன் பேங்க் இருக்குன்னு சொல்றீங்க. பட் இந்த மெசேஜ் வந்து ஜாஸ்தியா யாருக்குமே ரீச் ஆகலையே. நீங்க சொல்றீங்க 2000ல இருந்து இருக்குன்னு சொல்றீங்க. எனக்கே ஆக்சுவலா தெரியாது.
Yes, sir. This is established in MMC long ago when we are postgraduate. That time itself it was functioning. But the thing is,
start பண்ணது எவ்வளவு 2006ங்களா?
2004 itself, 2003 we did a allograft from Sri Lanka. We harvested. I mean, we took it from there, and we did the first allograft was done by Professor Mailwangan here in 2003. When we were postgraduates at the time. And the bone bank was established here in 2008 itself.
அதுதான் சார், நீங்களும் ஒரு ரைட் அப் நல்லா கொடுங்க. நீங்களும் யூ ஆல்சோ கிவ் a ரைட் அப். அண்ட் நீங்களும் கூட வந்து எப்படி வந்து கவர்மெண்ட் இன்ஸ்டிடியூஷன்ஸ்ல இதெல்லாம் கொண்டு போறது அப்படின்னு சொல்லி, நாங்க பிரைவேட் இன்ஸ்டிடியூஷன் பத்தி எவ்வளவு நேரம் பேசிட்டோம். கவர்மெண்ட் இன்ஸ்டிடியூஷன் அண்ட் கவர்மெண்ட் ரூல்ஸ் அண்ட் ரெகுலேஷன்ஸ் அது தனியா இருக்கும். அதுல கொஞ்சம் ஹிச்சு கொடுத்துட்டே இருப்பாங்க, இது பண்ணக்கூடாது அது பண்ணக்கூடாதுன்னு சொல்லுவாங்க. சோ அதனால நாங்க இப்போ ஸ்கின் பேங்க் இதே லாஸ்ட் மந்த் மீட்டிங்ல பேசிட்டு இருந்தோம். அட் த டைம் we had the difficulty how to take the skin. Even natural death patients எல்லாம் நம்ம வந்து ஸ்கின் எடுக்கலாம் கவர்மெண்ட் ஹாஸ்பிட்டல்ல. எடுத்தா ரொம்ப ஸ்கின் வரும், அது எடுக்கிறதுக்கு அலோவ் பண்ண மாட்டேங்கிறாங்க. That is the problem. We should have a clear cut idea. அப்படியே ஒரு ஜீவோ மாதிரி போட சொல்லணும். We should ask them to do it. Transplant மூலமா பண்ண வைக்கணும், ஏதோ ஒண்ணு பண்ண வைக்கணும். அப்படி பண்ணாதான் பண்ண முடியும்.
Yes, sir. Really, I am glad that IMA has taken a very good initiative to make the organ donation is a big process. We can do it better, sir. Yes, sir.
அதான் நீங்க வந்து ஒரு ரைட் அப் கொடுங்க. எல்லாம் வித் தட் வந்து நீங்க வந்து இப்போ கவர்மெண்ட் இன்ஸ்டிடியூஷன்ல ஃபார் எக்ஸாம்பிள் எம்எம்சில வந்து எப்படி போன் வந்து கலெக்ட் பண்ணுவீங்க அப்படின்னு அவங்களுக்கு ஒரு இது. அப்ப எப்படி எடுக்க போறது? அட்லீஸ்ட் நீங்க இருக்கிற கவர்மெண்ட் இன்ஸ்டிடியூஷன்ல எப்படி கலெக்ட் பண்றீங்க? யூ கேன் கலெக்ட் இட் ஃப்ரம் தி அதர் இன்ஸ்டிடியூஷன்ஸ் ஆல்சோ. ஸ்டான்லில இருந்து எடுக்கலாம், கீழ்பாக்க அங்க இருந்து வாங்கலாம். லைக் தட் யூ கேன் டு இட் அண்ட் கீப் இட். இப்போ உங்களுக்கு வந்து ஸ்டெரிலைசேஷனுக்கு வந்து காமா வெச்சிருக்கீங்களா? காமா ரேஸ் வெச்சிருக்கீங்களா?
அதான் சார், அங்க ரேடியோ தெரபில இருக்கு சார். we have காமா ஸ்டெரிலைசேஷன் ரேடியோ தெரபி.
இல்ல நீங்க அங்க வந்து அனுப்பிட்டு நீங்க அங்க ஸ்டெரிலைஸ் பண்ணி வாங்குவீங்களா?
Usually weekend they will allow us to do, because routine cases they will do all the weekdays. So we will post cases according like that. Saturday பண்ணி Monday போற மாதிரி we will plan. அதுக்கு முன்னாடி before that we used to do ETO sterilization. ETO sterilization யூஸ் பண்ணிட்டு இருந்தோம். Now we started doing that gamma also.
Sir, Chandrakumar sir, how about the ETO sterilized bone can be used, or gamma is to be compulsory?
Some people use ETO, sir. The problem with ETO is it is considered as a carcinogen. Sometimes the ETO residue is there in the bones, and it has proven to be carcinogen. So that is why these associations they promote radiation as the best sterilization method, sir.
So how much power usually used to be put on the bones, sir, actually?
Radiation, sir. How much
sterilization?
25 kilogray, sir.
25 kilogray. Gamma rays.
Yes, sir. Gamma rays.
So you will send it to Kalpakkam and also Bangalore.
Yes, sir. Yes, sir.
So I request all three of you all, sir, Din Mohammed sir, Chandrakumar sir and Pasupati sir, all three of you, please give a write-up about this bone donation. what are the things you have taught? Whatever the message you want to send it to the public, you can give it. And we will conduct regional workshops in East Zone, North Zone, South Zone, like that. Initially, since you are in Chennai, we will initially start a workshop in your center within a month or 2 months, once in 2 months, within a month or next 2 months, convenient days, we will announce, and we will try to bring more people so that let it be an initiative, so that the next meeting we will have once in 2 months, like that. We can conduct the workshops like that, so that more people will be knowing about this bone bank. At the same time, we can send the message and we can get more of the bones. That is the main aim of doing it, sir. We will try to get it. So that will be a good initiative and we will be able to get more bones. There is one question, is it 3D printed synthetic or something?
Regarding ETO sterilization was accepted by the European guidelines those days. And nowadays, only gamma sterilization is accepted. That is the only way we can use the allogenic bone. We cannot use it as ETO. And as per the WHO guidelines, it is not accepted.
Professor Pasupati sir.
Yes, sir.
Sir, ಈಗ ನಮ್ಮ ಗವರ್ಮೆಂಟ್ ಜನರಲ್ ಹಾಸ್ಪಿಟಲ್ல ஏதாவது ப்ரொவிஷன் இருக்கா பிரைவேட் டாக்டர்ஸ் வந்துட்டு போன்ஸ் அனுப்புறதுக்கு to transport bone? Any provision is there?
So far, we have not initiated anything like that, sir, because even from other medical colleges, as Dr. Rajesh said, we are not able to coordinate well with that. We are writing to the DME and DMS about this from Dr. Ismail time itself. But we are right now harvesting only from our institution and keeping. We will try on this, sir. That will be better idea, because in the bone bank, like
Sir, Chandra Kumar sir, regarding the bone for outside people, whether you are providing bone for outside people if they request, and
Yes, sir,
what will be the charge you are charging approximately?
If it is a general ward patient, for up to 5 gram of lifeless bone, it will cost around 3,000, sir. And one femoral head freeze-dried will cost around 5,000, sir. We provide for outside patients also.
Oh, that you provide it in the bags, or it has to be transported in a cool segments like that?
No, sir. The freeze-dried bones will be at room temperature, sir. It will be vacuum packed, and it will be stored at room temperature. It will be triple packed. So we'll give it like that. If it is a deep frozen bone, then we'll transport it in that ice bag.
Yes, sir. So there is one question. Why bone banks are not yet opened in all government medical college hospitals, sir? So that regionally graft will be available in all cities, sir. That is one question. From one of the...
Madurai has a bone bank, sir. The Rajaji Government Medical College has a bone bank. I think Tirunelveli or Toothukudi, they also had come and visited our bone bank. Even the Madurai people, they had come and visited our bone bank. They trained here for 1 week on establishment and how to run a bone bank. Tirunelveli also, I think they had come and trained here for a week on how to run a bone bank. I think they have started or not, I'm not sure, sir.
Madurai, they have already started. They are using it now. The problem is the gamma sterilization. So wherever it is available, it is not available because there is a quite waiting list for the patients. So they are not able to find time to sterilize these allografts. That would be the limiting factor. Availability of bone is one thing, that is not that very a problem. But having a gamma sterilization is a limiting factor.
Is it difficult for it to be outsourced, sir? Like you can send it to Bangalore and they do it at a very cost-effective price, the radiation.
Sir, that's what we will do is we will conduct a small workshop like that so that everyone will be educated, sir. Because most of the people, even the orthopedic people may not be knowing more about this bone back and the procedures. We will try to bring the association people also into the picture, the orthopedic association, so that we will be able to do like that. Sir, you please unmute yourself.
Yes, sir.
Sir, there is one more question. Is it 3D printed synthetic bone superior to these cadaveric bone grafts?
So the 3D printed synthetic bone, I'm not very sure, sir, how much it is available, what it is. I have no idea about it, so I won't be the right person to comment on it.
Right now, we don't have any 3D printed bone substitute. We have 3D printed bone models with which we plan the surgery. That we do. People at IIT, they were able to give it totally free of cost to government general hospital. But 3D printed synthetic bone is, as such, is not available. It is available in the form of when we do a 2-stage revision hip replacement, we can keep a bone like a synthetic substance inside the medullary canal with impregnated with antibiotic. That is being used.
Sir, one more question, sir. Why bone? What is the procedure to procure bone graft from Chennai to other cities, sir?
In the government setup. Sorry, you go ahead, Chandra Kumar, please.
You go ahead.
In the government, as far as the government side is concerned, we tried our level best to make this one possible, but at the time we were not able to make it happen. They wanted some GOs regarding that. But as such, in a private setup, at least in a quasi-government setup like a cancer institute, I think it's very much possible. You can request that, and it can be sent.
We have been sending bone grafts, sir. The freeze-dried can be transported. Like I told, it's stored at room temperature. And deep frozen bones, there are various cold chain storages, sir. You can speak to them. There are various logistics. So they transport the bones, sir.
So,
we cannot hear you, sir. I don't know whether.
So you are not audible, sir.
sir, what we can do is we will conduct zonal wise the small workshops like that, and we will explain them what are all the things done. You can show that. That is first initially we can have it in Chennai itself. In your institute itself, we can conduct a small workshop like that. Who are interested can come and attend, and they will be benefited. So that like that in other places, if for example in Madurai it is available, we can get a Madurai thing like that, and like that we can spread message, and we will try to get more bones, and we will procure more bones. That is the main aim of myself, sir. So I request all three of you to please give a small write-up about the bone donation, so that it will be very much useful.
Sure, sir, sure. I would like to thank IMA for taking this initiative.
Sir, if there are no questions, I request Kalidas sir to give a vote of thanks.
At the outset, see the very purpose of this today's CME is to create awareness about the bone transplant and the Allograft substitute for the beneficiaries, especially in the doctors community as well as the orthopedic surgeon. In this juncture, as the orthopedic surgeon, I request the TNOA President, Dr. Ismail sir, to at least during coming conference, a 15 minutes program to create for a bone transplant awareness in our TNOA conference. And also, I request Professor Patupri sir to create awareness in the MOS society. Like that, you pass it on all the messages to all the district orthopedic societies for the secretaries and presidents of respective districts to create an awareness about the bone transplant and its usage, so that all the orthopedic surgeons will come to know about the importance of procuring the bone and transport to the respective bone bank centers, and so that the public will get the benefit out of this. With this word, I thank Professor Dean Mohammed Ismail, President of the TNOA, for coming here and give his lecture. Thank you very much, sir. And Professor Patupri sir, thank you very much, sir, for your time, spending valuable time. And I thank Professor Chandra Kumar sir. Thank you for your elaborate lecture and clearing all the doubts. And I thank our President, TAMILNADU IMA, Abulasan sir, the Secretary, Dr. Karthik Prabhu sir, the immediate President, Dr. Sengutuan sir, other dignitaries, especially not the least our Rajesh Babu sir, program. And I thank all the committee members and the participants who are all participated in this program today. Thank you very much for all your cooperation. Thank you one and all. Long live I. Thank you, sir.
Thank you for the opportunity.